We described the influenza life cycle and the mechanism of action of endonuclease and neuraminidase inhibitors. Now let's distinguish between influenza, rhinosinusitis, pharyngitis, and other acute respiratory illnesses using patient-specific factors, clinical manifestations, and diagnostic testing. Rhinosinusitis is inflammation of the paranasal sinuses. In acute sinusitis, the symptoms last less than 4 weeks, whereas in chronic sinusitis, the symptoms are beyond 3 months. And in between that, you have subacute rhinosinusitis. Now, if you have rhinosinusitis due to bacteria, we call that acute bacterial rhinosinusitis. And of course, if it's due to viruses, we call it acute viral rhinosinusitis. And then we have acute pharyngitis, which is primarily sore throat that usually lasts 1 week. There's also acute bronchitis, which is the productive or non-productive cough that lasts up to 6 weeks. There's the common cold, which is a mild upper respiratory viral illness that usually comes with sneezing and rhinorrhea. And of course, we have allergic rhinitis, which is a non-infectious immunoglobulin-mediated reaction against inhaled allergens. The symptoms of acute rhinosinusitis include nasal congestion and purulent nasal discharge. And if you keep in mind the anatomy of the sinuses, you'll see that these patients can also have maxillary tooth pain, facial pain, or pressure. And of course, these patients can also have fever, fatigue, cough, hyposmia, or anosmia, which is basically reduced ability to smell or the lack of ability to smell. They can also have ear pressure or fullness, headache, and halitosis. Symptoms usually last between a day up to 33 days, depending on what's the underlying cause. And what's important to note is that 85% of patients actually can have at least reduction or sometimes even resolution of symptoms within 7 to 15 days, especially if these are viral infections, and that's without antibiotic therapy. So in studies where the groups were receiving placebo, they actually had a high percentage of patients actually have resolution of symptoms. Now, when it comes to acute pharyngitis, there's a triad of sore throat, fever, and pharyngeal inflammation that are the hallmark of acute pharyngitis. And this sore throat is worse with swallowing. The pharyngeal inflammation is characterized by erythema and edema, and it usually lasts for 1 week. From the IDSA Guidelines for rhinosinusitis, for diagnosis of rhinosinusitis, they have major symptoms and they have minor symptoms, and their criteria is that a patient must have at least 2 major criteria in order to be diagnosed, or they can have 1 major plus 2 or more minor symptoms in order to have a diagnosis of rhinosinusitis. Now, gram stain and culture from the sinus puncture is not routinely done because it's invasive, time-consuming, and perhaps painful for the patients. Now, it's important that if you use this criteria to diagnose the patient, it doesn't really distinguish between whether it's bacterial or viral infection. So that also needs to be determined. So here are the criteria that IDSA has set to distinguish between bacterial and viral. So if the patient meets any of these 3 criteria, there's a good, you can suspect bacterial rhinosinusitis. So one is if the patient has persistent symptoms or signs compatible with acute rhinosinusitis for at least 10 days. And that's because viral infections typically resolve by day 10, whereas bacterial infections typically persist through 10 days. Now, before the 10 days, if the patient has severe symptoms or signs of high fever, so 39 degrees centigrade or higher, and purulent nasal discharge or facial pain lasting for at least 3 to 4 consecutive days, that's suggestive of bacterial infection. As well as if the patient has the double sickening. So if the patient was initially improving and then followed by worsening That's referred to as double sickening or double worsening, and basically the first part of it was due to viruses and the second part is due to bacterial growth. So that's also suggestive of bacterial rhinosinusitis. Now, in patients with acute pharyngitis, only a small portion of patients actually have the infection due to Streptococcus pyogenes. In fact, in adults, only 5 to 15% of these infections are due to Streptococcus pyogenes. And the reason we are talking about Streptococcus pyogenes is that this organism specifically can lead to some serious complication. In general, we break the complications into suppurative and non-suppurative complications. So basically the suppurative complications involve post-discharge. So these are things like abscess, mastoiditis. But what I want to bring your attention to is the non-suppurative complications, which include glomerulonephritis, so in the kidneys, but as well as acute rheumatic fever. And what's significant about acute rheumatic fever is that someone with acute rheumatic fever can actually have a resolution, but if it doesn't resolve on its own, it can actually lead chronically to rheumatic heart disease. And what's significant about rheumatic heart disease is that it can actually lead to heart failure, atrial fibrillation and stroke, and also death. So this is why we emphasize treatment of Streptococcus pyogenes pharyngitis. Now here are the IDSA criteria for distinguishing between group A streptococcal pharyngitis and viral pharyngitis. So the most important is absence of fever suggests that it's a viral pharyngitis, whereas if you do have fever as part of the triad, it's more suggestive of group A streptococcal pharyngitis. Now, if you use these criteria, it's more suggestive. It doesn't really confirm. So if someone has fever, it still needs to be confirmed by bacteriologic culture. So what they do is that you actually swab the throat, or the clinician will do a swab of the throat and do a rapid antigen test for group A streptococcus. So if this test positive, then the patient will be diagnosed with group A strep pharyngitis. And now if it turns out to be negative, there's no need for confirmation in adults because there's a low incidence of group A strep pharyngitis in adults. Now in children, it is recommended to confirm it if it's negative. Now because strep pharyngitis is contagious, you might think that if somebody gets it, you should test all of the household members, but that's actually not recommended. Now let's take a look at clinical manifestations of influenza. Patients with uncomplicated influenza typically have fever, chills, headache, myalgia, malaise, and anorexia, which are very non-specific. Now, in order to distinguish influenza from pneumonia, it's important to note that people with influenza have dry cough, so there is no sputum production. And some individuals can even be asymptomatic. And in uncomplicated influenza, symptoms typically last 4 to 5 days. Influenza can also be complicated, and there are, generally speaking, 4 categories of complications. The first complication is primary influenza viral pneumonia. Now, while uncomplicated influenza is typically an upper respiratory tract infection, when the virus makes it to lower respiratory tract, it will cause primary influenza viral pneumonia. And because this is pneumonia due to influenza virus, it's a virus, so when when we get a chest x-ray on the patient, there's actually no consolidation. So when you see no consolidation, that means that it's unlikely to be due to bacteria. So it's very likely to be a viral infection. Now, because it is viral pneumonia, because of the pneumonia part, now the patients are going to have more hypoxia. So there is a problem with oxygenation. And of course, if we get a sputum sample and we do gram stain, there will be no significant bacteria seen. And no bacteria will be grown on sputum culture unless normal flora. Now, one thing that will diagnose viral pneumonia for sure, if on the sputum sample, if we do a reverse transcription PCR, if the PCR is positive, that actually confirms viral pneumonia, viral influenza pneumonia. Now, these patients, of course, will not respond to antibiotics because it's a viral infection. However, because it's pneumonia, mortality is high. Another complication that can happen is secondary bacterial pneumonia. So once the patient get the viral influenza, it will be followed by a period of improvement lasting 4 to 14 days, followed by recrudescence of fever associated with signs and symptoms of bacterial pneumonia. So basically, during the first phase, the virus will be cleared. However, in the meantime, bacterial infection will be incubating. So while the bacteria are growing, the patient will be improving, and then once enough bacteria have grown, that's when the patient starts to deteriorate again, and then followed by symptoms. And the reason, and the way we will actually diagnose secondary bacterial pneumonia, and the reason we call it secondary is because this is secondary due to the actual primary infection, which was influenza. So influenza is the primary infection, and then the bacteria will be secondary to the influenza. So this time, because bacteria are involved, on the chest x-ray, you will see consolidation. And of course, it's pneumonia, so you will have marked hypoxia. And this time, on sputum culture, you will start to see growth of bacteria. Now, of course, not every patient will grow bacteria on the culture, but if you do see bacteria growing, that confirms bacterial pneumonia. Now, with infection control in the hospitals, influenza outbreak is not very common in the hospitals, so by far majority of influenza causing secondary bacterial pneumonia is from the community. So for the most part, these are community acquired pneumonia. But one thing that's special about influenza causing pneumonia is that the common pathogens are Streptococcus pneumoniae as well as Staphylococcus aureus. So because Staphylococcus aureus is one of the top two organisms causing secondary bacterial pneumonia, then the question is, should you cover for MRSA or MSSA coverage empirically is enough? So community acquired pneumonia guidelines basically have risk factors for identifying those at risk for MRSA, which also apply to this. For critically ill patients, however, empiric MRSA coverage is recommended by the influenza guidelines. Now, here's a list of risk factors for actually having complicated influenza, which I let you read. This is according to the CDC.